Russell, for that great introduction. I am ready, and if I can have my presentation up on the screen, that will be great.
Hopefully somebody's got that. I know I don't. Okay.
Sandy and I think, yeah, another person. Dave, thank you so much. So I do want to start just taking a kind of a minute to thank the group and the ECHO program. I am feeling really sad about the fact that this is our final meeting. I really, 3 o'clock on Fridays has become my favorite time. It's kind of been the highlight of my week, and I feel like I'm in some kind of grief, and I might need some grief or loss counseling here. Yeah, this is hopefully, you know, we'll figure something out and bring this back. And I tell you, I have benefited tremendously from the wealth of knowledge and expertise, as well as the support I received through this group. Thank you so much. And I am honored to provide you with this presentation today. Before I start, I would like to do a little information sharing introduction about myself. So I was born and raised in Turkey. So I'm a native speaker of Turkish, if you need any Turkish translators. So I'm always available to help. I have actually started out as a nurse in Turkey in a research hospital. And then I decided to transition to counseling as my long-term career. And I have studied at the Ohio State University and got my doctorate degree in counselor education. And I have done some teaching. I have worked in the community behavioral health system for many years. I have also worked for Ohio Department of Mental Health and Addiction Services in the evidence-based practices, health homes, integrated care, before actually transitioning to managed care. I have joined Aetna, my care plan. I worked there for 5 years and helped implement Ohio's dual benefit Medicare Medicaid program. So the last 2.5 years, I've been with the Freedom Center. I wear multiple hats here. I'm the executive director as well as the clinical director. And I do still see patients and keep a caseload. And so today's presentation is really about our efforts to bring medication-assisted treatment and medications for opioid use disorder in our jail in Knox County. So let's go to the next slide. Next one. Thank you. So I do want to start with a little background about this federal grant program called Rural Communities Opiate Response Program, RCORP. This is a program that actually is with the Health Resources and Services Administration, which is part of Health and Human Services at the federal level. So I think most of you know that when you're starting a new program, it can be very costly. You need money, seed money, or startup money. So, and grants are a really great way to go about getting that money to, you know, put together a program on the ground. So we've been ready for this, and we were kind of waiting for the right time and also the funding source. And you know, we really owe the program to this federal grant. It wouldn't have been possible without this RCORP grant that we received. Next one. Okay. So Rural Communities Opiate Response Program is a multi-year initiative. I believe it started back in 2018. The main purpose of it is to address any barriers to substance use or opioid use disorder treatment in rural areas. And it really works to kind of support the Health and Human Services goal for eliminating or ending the opiate epidemic crisis in the United States. Next. The goal of this, again, program is to reduce morbidity and mortality of substance use, specifically really with a special focus on opioid use disorders. And I underlined the high-risk rural communities. So it's interesting because HRSA does not actually define high risk. So it is left up to the community itself to really kind of justify, explain, kind of quantify what that means for them to be high risk. So that was something that we really had to pay attention to during our grant writing process. Just to kind of give you a little bit more background information about the ARCOR program. It's actually housed in the Federal Office of Rural Health Policy in HRSA. And this program bureau oversees 5 different grants, including planning grants, implementation grants, medication-assisted treatment expansion grants, neonatal abstinence syndrome grants, and psychostimulant support grants. The psychostimulant one is new because they are really kind of responding and evolving to the, the on-the-ground situation with the stimulant crisis we are having. And they just added that last year. And in fact, we applied for that grant to supplement our opiate use grant. And we did not receive it, even though we had a very high score, because it was a highly competitive grant. So basically, HRSA invested close to $300 million in these programs. And this started in 2018. And they have given funding to over 1,400 counties, rural counties in the United States. They also have 3 different coordinating centers of excellence. And these COEs, actually CCOEs, they look at the evidence-based practices and interventions. They try to identify, translate, and disseminate these in rural communities. Next slide. As I mentioned, the focus is rural communities, and a little bit about the Knox County. We are a rural county, and we are also a health professional shortage area. We have shortage in all areas: medical, behavioral health, dental. So this is the main qualifying criteria actually to apply for this grant. Next. So the goal of the grant was to really strengthen and expand the substance use and opiate use disorder prevention, treatment, and recovery services. And this is a 3-year grant. For ours, it was September 1st, 2020 through August 31st, 2023. So it's the 3-year, and then it's in the amount of $1 million for this entire 3-year period. Next. So just a little background about the process. When this grant announcement came out, it was back in February 2020, right before COVID hit and the shutdown came. And we actually had one meeting as a community because this was brought to our attention through our health commissioner, who's over our public health in Knox County. And she saw this and she reached out to a bunch of community organizations and wanted to see if we would be interested in applying and creating a consortium, because the grant requires a consortium approach. So you must have at least 4 different organizations coming together to even be eligible to apply for this grant. So that was the beginning. And of course, COVID came and we were not able to really do anything about this. We couldn't even get together, and it got put on hold. And so somebody had to kind of step up and bring it back. And so I kind of volunteered and worked with all the other organizations and the partners, and we decided to go for it and write the grant. And I have to tell you, I think I felt great during the whole early COVID shutdown and the crisis, because I was so distracted focusing on this grant and writing this grant that I tuned out everything else. So it was a very intense experience, and we ended up actually having a very big consortium. And we had to name our consortium, and we had to come up with a logo. So you're looking at our name, Knox Opiate Response and Recovery Corps. Everybody liked that. And then we also developed the logo. You're seeing our logo in the bottom there. And we were very proud of it. And this was a lot of work and really took a lot of teamwork. And we did this during this, like during the heat of COVID and COVID crisis. And moving on to the next one. I think that still that consortium concept or approach to these grants is really a key, I would say, key area from the federal perspective. We got the sense that all along, they really wanted to make sure that the rural communities, like organizations and partners came together. And they make that a requirement. So we still get a lot of questions, and we get measured on a regular basis about the health and the strength of our consortium and our partnerships. And so this is something that we really learned a lot about through this grant process. But we understood that opiate addiction or opiate epidemic is a very complex and difficult, challenging crisis and issue, and really requires a whole community, and it requires a multifaceted approach. And we knew that no one organization could really take this on. So that was the premise for our consortium. Next. So we set our goals. Our purpose was to, of course, improve access to evidence-based, integrated, sustainable prevention, treatment, and recovery. And the goal was to reduce loss of life and illness. So we ended up actually creating a work plan addressing treatment, prevention, and recovery, because those were all required components and we couldn't leave anything out. We ended up with 29 different projects, and they were all very integrated and required multiple organizational involvement. So it was a very comprehensive grant and very ambitious grant. Next. So here's our consortium, and you're seeing everyone, all the 13 different organizations that became part of this consortium, starting with our ADAM board, MHR board of Licking and Knox counties. They were our applicant, and they are our applicant organization. We had to choose an applicant organization. That was a process we had to go through as a consortium. And our board was very willing to really step up and take on that role. The Freedom Center, my organization, was, again, involved, and we are one of the treatment providers. BHP is our lead mental health treatment provider in our county. Community Roots is a nonprofit organization. They do use agricultural, approaches to really sobriety, and they kind of really support recovery communities. The main places are peer-run consumer operated service center. And we have the municipal court, and they actually have a drug court, merit court, and they have been a big partner. We have Riverside Recovery, another addiction treatment provider. Touchpoint is a faith-based nonprofit community organization that's a partner. And we have our sheriff's office, and our sheriff has been very active, very involved in this process. Pathways of Central Ohio is our 211 referral, and also they run a hotline for our county. And we have our felony court. They also have a drug court called Armor Court, and our FQHC, our Knox County Community Health Center, and of course Knox Public Health. So this is the entire consortium. As you see, it's a very diverse group of organizations: governmental, non-governmental, for-profit, not-for-profit, faith-based. So it was a very diverse group, and we came together, and it was really amazing. We did this during COVID and during shutdown, and we had to do this virtually and pulled it together. So I'm very proud of the consortium, and the consortium is still intact. All the partners are still in place, and we meet regularly, and there's a really robust participation. Next. So kind of narrowing down on the Knox County Sheriff's Office and the projects that they agreed to implement as part of our grant. So first thing we wanted to do was start a universal SUD screening in the jail. We knew that the jail had a high proportion of inmates with substance use issues, and they did use an assessment tool, ask some questions, but they were not really a validated, reliable screening tool. There was just a couple questions related to alcohol, drug use. And so the first thing we did was propose universal screening for SUD for every inmate that gets in the jail. And the second project was really to provide at-risk education. So as we identified people who are at risk in the jail, as we screen them, we wanted to make sure that they had access to substance abuse education program. And the third project was really the big one, and the entire consortium was really very supportive of this one, to implement medication-assisted service in the jail, and specifically kind of using Rivitrol as the MOUD here. And the fourth project was, this actually was proposed by our executive director of our FKHC Community Health Center. He really wanted to do something around preventive dental care, oral health. So he proposed that individuals who were in the MAT program in the jail also be screened for dental oral health needs and be linked to his FQHC dental office for a preventive dental care. So these were the projects, and it was very ambitious, like I said. Next. So here's pictures of our, so just to kind of give you some visual, information there. You see the jail, and it's a relatively small, rural jail, but I would say, I mean, I think they have over 2,000 inmates that they process per year. So it can get very busy in the jail. And you're also seeing a picture of the Freedom Center. And I am in the second floor right now, looking up the street on the porch. And so this is a very old building, historic. It's on the National Registry of Historic Homes, and it's over 180 years old, still standing. And so I love coming here to this building every day. It's just really worth seeing. So basically, the MOUD program in Knox County Jail is a partnership between the Knox County Sheriff's Office and the Freedom Center. And so let's go on to the next one. So we knew that jail didn't have an MAT, services, and if somebody was on MAT and they got arrested and put in jail, there wasn't a way for them to continue to stay on their medication-assisted treatment or their medication. And they were also facing, of course, withdrawal in the jail because they didn't have access to the MOUD. So the goal was to, and we also knew that people, based on the research and literature, individuals who are in jail or in prison are high risk for overdose and death because of the reduced, tolerance. And so there was a really good reason for us to make the case to implement the program in the jail, and there was a lot of support from the community. So next one. So our goals for the program, again, reducing that post-release opiate and substance use relapses, minimizing the risk of post-release overdose and death, increasing and improving substance use treatment post-release. This is more about linkage and engagement and initiation of treatment in the community, and creating, and again, a pathway of recovery for individuals with opiate use disorder, and also helping the jail and helping creating a safe and secure facility for inmates and staff. We wanted to make sure that we were looking at this project through the eyes and the lens of the jail administration and our law enforcement partners, and really we had to work very hard to understand their culture, their requirements, and really be sensitive to that. So we tried to come up with some goals that really both parties could relate to. Next. So some of the basic areas that we really had to focus on during the design and implementation process was looking at the program design. And this required a lot of basically research and consultation and talking to other programs around the country or the state, and really looking at all the publications that were available about starting a MAT or MOUD program in a jail or prison setting. So really we had to do a lot of education research before we really decided on the design. And then we moved into really kind of creating that program description, the flow, and creating the forms that were going to be important to the program and day-to-day work. And but one of the important beginning initiation is that what kind of screening tool do we need to go with in the jail that will help us identify basically inmates who have substance use issues, may benefit from maybe education or some intervention, as well as maybe those that really will benefit from the medication-assisted treatment in the jail. So we had to kind of work on selecting a valid, reliable screening tool. And we looked at a lot of different tools because we are going to do this in the jail, and we needed the help from the jail medical staff and the corrections officers. We wanted to make sure that it was a tool that was easy to implement and wasn't very burdensome. So we ended up deciding on the Cage 8, 4 questions, self-administered, very easy tool to use, and we've been using that for a while now. It seems to be working out, but again, we wanted to make sure that we were open to changes if we decided that it didn't work or we needed to improve. Another big key area was deciding on the type of medication for opiate use disorder. Again, our literature, our research, our consultation with other programs in the state, we could see easily and quickly that Vivitrol was a commonly implemented MOUD and was widely accepted, and the law enforcement community understood and knew what it was and really supported it, and didn't have much stigma compared to some of the other MOUDs that we had. So we decided early on that we were going to start with Vivitrol. And so that was the medication that we agreed on and selected. We also had to decide on the eligibility criteria for the program, and we wanted to come up with a process for how inmates, offenders could participate in the program and the requirements around that. And also then we had to have a team. We had to recruit a team, a medical professional who was willing to go into the jail and really provide the MAT services. And also we needed a counselor and coordinator support staff to really help with the program. Of course, we are in this is a grant funded project, and federal grants come with a lot of data tracking and reporting. And so we do quite a bit of that, and that also had to be set up. And the last thing was really, and I realized, this is a great practice, having a memorandum of understanding, MOU, especially in a project like this that is very critical and important to the community. So we ended up actually working on a very detailed MOU, had our attorneys look at it, the prosecutor's office with the county, because they support the sheriff's office, they looked at it, and we also developed the MOU and signed it. So that was a really good component of this, this implementation process. Next. So here's our flow. This is kind of how we try to actually follow this flow pretty much. The clients get screened for substance use or opiate use at booking or intake. Now it's happening at actually intake. And then they are assessed by our chemical dependency counselor in the jail. We have a position for them. It's actually SUD linkage coordinator for the jail. They do the assessment, and then when they determine that the person, the inmate, meets the criteria for the MAT services, then she makes the referral to basically to the MAT program and schedules that client individual with our nurse practitioner for initial medical, exam and assessment and lab work. And once everything checks out and the person is eligible and they're medically cleared, approved, then they can start the withdrawal protocol. And we also provide, of course, supportive services, counseling, case management as part of the program in the jail. And we try to target inmates that are within 90 days of release, so that we're not starting too early or not too late, because sometimes we can't really catch them. It takes time to really initiate the withdrawal, and there are several steps, so sometimes they're out too quickly. So we try to target those that are within that 90-day release window, and so we can then start the release services, and that includes looking at if they need to get on Medicaid, if they need other services like housing or other supports and resources. And then a big part of it is also making sure that there's a linkage to outpatient community-based medication-assisted treatment program so that they can continue their Vivitrol shots once they're released. And the goal is to release them with a project down kit. Right now, we are not doing that component, but we're working hopefully to implement that last step. Next. Here's the inclusion criteria for the program. Again, anybody who was on Vivitrol prior to their arrest or incarceration, they're a priority. Of course, clients who are high risk for overdose, based on their history and assessment, they are a priority for this program. Anybody screens positive for opiate, because this grant only supports opiate use disorder. So we have alcohol, but we really just focus on opiate using the grant dollars. And then the diagnostic criteria. And we make sure that the client is really motivated to participate and follow through with all components of the program. That includes, follow up with the community-based program, MAT program. Of course, they also need to agree to, kind of giving us permission to share information or coordinate care in the jail with the jail medical team. Of course, they can't be pregnant, and of course, they can't test positive for opiates before their tolerance trial. So these are the inclusion criteria. Next. And we have some exclusion criteria as well. We try not to refer clients who are in pretrial status. We don't know whether they're going to go on to prison or, and there may not be an opportunity to continue, or they may not be able to be released to the community. So we need to know about their status before we start the treatment program. And so that's something that we do screen out. And then, of course, liver enzymes, interferon treatment, therapy, or if they refuse to really participate in all aspects of the program, or they don't sign the required legal forms, we look at them as legally required forms, pretty much like consent, participation agreement, or if they're pregnant. Next. So we have, like I said, we had to have a really the right team and the staff to be able to really do this successfully and do it really well. So we had a jail program coordinator in the jail. This position was funded partly by the county board, the MHR board, and also we receive a state jail grant through our municipal court to support this position. So we used part of the grant, the HRSA grant as well, to support this position to help with the MAT program in the jail, and as well as doing some of the linkage and the discharge coordination. So this is a very important role in the jail. This person does a lot of great work, and actually we have her with us today along with our nurse practitioner. But they do all, like the entire continuum of SUD services, starting with screening or assessment, education, counseling, case management, urine drug screening, and a lot of course, the discharge planning and linkage is a big part of it. Next. And our nurse practitioner, she provides professional services, including medical assessments, ordering labs, prescribing. She's really responsible for transporting, controlling, and administering the Vivitrol in the jail. And also she does the health and dental screening and the referral to the health department or health center for the dental care, and also care coordination, information sharing with the jail medical team. Next. Here's our kind of preliminary data for the program. So we launched this back in April, so it's relatively new. And so at the beginning, we had 4 participants during that month, and then it went down to, I believe, 2. We stayed there through June, and then we're down to 1 now. So we're learning a lot. We did have some staffing changes in the middle of the program implementation. We are optimistic that we will ramp up. We got some good practices in place now. We revisited some of the components, and now we are able to screen and identify and capture a larger population who really can benefit from this program. So our hope is to really be able to engage and do a better job engaging and recruiting clients who want to really do this program. So, but this is the initial data. I know the numbers are small. Like I said, we were conservative and really cautious. Wanted to start small. We wanted to make sure that the program components worked okay, and we didn't want to have a high risk situation or a really negative outcome, because it took a lot of work to put this program in the jail. And I often feel like we can't really afford to make a mistake or have a negative outcome, and kind of have the program shut down or not go anywhere. So we are moving very cautiously and very carefully while we are learning. We are becoming more confident. I'm hoping that the numbers will go up the second year of the grant. Next. So I want to go ahead and introduce the team. If we can have Debbie and Mandy, I think they're together in the jail right now because they just, I believe, saw a patient and gave a vivitrol shot. So if we could unmute them, or if they could unmute themselves and introduce themselves and share a little bit about themselves and their work, that would be awesome.
Hi, I'm Debbie Werther. I'm the counselor AOD educator out here. I meet the inmates and assess them and see if they're interested and or eligible to be in the MAT program. And then my next step is to refer them to Jennifer, and then she takes over from there.
Hi, I'm Jennifer. I'm the nurse practitioner with the MAT program. Once I receive the referral from Debbie, I will come in and do a physical assessment, give orders to pull labs. I usually check their complete blood count, comprehensive metabolic panel, check their liver functions to make sure that they're not, an active hepatitis C symptoms, and make sure that the liver is going to take on the medication well. Usually within a week after the injection, I check up on my patients to make sure they're doing well on it, no side effects. Sometimes there are some side effects. So we always go over that before the injection, and even before the injection, we get a urine sample to make sure that nothing's being used while they're in jail, because that does occur sometimes. But yes, it's actually going very well. We have very good communication. That's one of the biggest things I have to say that is so important in this program. We have huge communication, and I usually, try to keep myself pretty open to any day that I can, because I do work at another job as well. So I also work at another different program for MAT. So a little bit of background about myself. I started from the bottom. I worked from an SCNA to an LPN to an RN to getting my master's degree as a nurse practitioner. I've been working MAT my whole NP career. So I really enjoy it. It's one of my favorite things. I love these patients. I love the inmates. They're more like family. So I really enjoy what I do.
Thank you, team. And Debbie and Mandy work so well together. I think one of the key components of having a successful MOUD in the jail is having the right team. And you can tell they both really enjoy this. And Mandy is local, so that was really helpful when we sat down and had these long meetings with the sheriff and his team, and having her at the table from the get-go and building those relationships. And the other thing about her is she's extremely flexible. She has never said no to us. She's very, patient-centered and does great with engaging with the clients and the patients. So we are so grateful to have her. Really, yeah, she does deserve that. And she's very committed to the program. So I don't think we could have accomplished this without Debbie and Mandy having such a good team and staff that's really committed to the success of this program. Next. So just wanted to touch on some key takeaways. So if you're thinking about implementing, starting a MOUD or MAT program in a jail or correction settings. The first thing I think I would say that community readiness is big. So I've been in Knox County for about 2.5 years, but I have worked with our MHR board and other organizations. They've been around a long time, and they have told me many times that they try to start MAT program and services in the jail for many years, and they couldn't really get it done. The timing wasn't right. The community wasn't ready. So there were some barriers to it. So I realized that, I mean, I wasn't around to really see that or know that, but my experience has been, wow, they're like great to work with. They're like really saying yes to me for anything I want to do in the jail. So, and my experience has been, and I realized that is because the community was ready. The conditions were right, and timing was right. And so it's important to really kind of assess the community readiness and really look at any barriers that you may encounter, before taking this on. And again, even if they're not ready, I think it's important to keep, taking small steps and working on some small steps, because it will take a while before you really get to that point of getting everybody on board and being able to have the actual program in the jail. The second thing is, I think that really what I noticed in Knox County, we are in a very special, I feel like very special community. There is a tremendous collaboration, partnership in this community. It's amazing how well organized the community is, and the organizations and the law enforcement, the criminal justice system, faith-based organizations, they talk to each other all the time. They get together all the time. So that was really a big part of it. All of our courts in this county, they are implementing therapeutic justice services. They all have drug courts. So that's really, you have the groundwork for it, and you can build on that. We also have a high participation in CIT trainings in this county. I mean, I think it's close to like 90% of law enforcement officers are trained in CIT. We have high participation in like mental health first aid training by the criminal justice system. We have ORT team on the ground. That's part, our peer support provider, our treatment providers, and our law enforcement. We work together on the ORT outreach. So we have really a community coalition. It's the Knox Substance Abuse Action Team. And they have every organization is part of that. So there is a lot of investment, cross-system collaboration and partnership, and that really makes our work as a treatment provider very easy when we have all the partners at the table, and we talk to them on a regular basis, and we get the support, and they really understand to some degree what we do. So the third thing is really leveraging existing efforts. So you don't really go from 0 to 100 miles here. There are other things that are in place that you really need to leverage. For example, what made it really easy for us to really implement this MAT program is we already had a jail program. We had a jail mental health linkage coordinator, which is a requirement for the state regulations for corrections to have mental health screening or assessment, and that was already in place. We also had a substance use linkage coordinator, and that was through the Freedom Center, and that position was funded through multiple partners, the Adam Board, we had the municipal court, and also the felony court, and the jail and the sheriff's office welcomed us and supported us in those efforts. So that was a big part of it, because we were able to go ahead and build on that to implement MAT services, and that made it a lot easier. I'm looking at my notes here, and I want to say law enforcement champions. So having our sheriff, Dave Schaefer, has been a great partner and a champion, and he was very consistent. Without him, we couldn't have accomplished this. And the interesting thing is, while I was writing this grant and proposing this specific project, and I was working with him, he was going through an election. And so here I am sitting, I'm like, and praying that, you know, he wins the election, because if, you know, if something changes, my partner changes, I may not have any program. So that was something that was really on my mind while I was writing the grant and working with him and thinking that he's going through an election now. And he won, and so he was still the sheriff, and really that was a big, you know, big relief for me. But not only we needed his support, we also needed his team, jail administrators, their buy-in. We also needed the buy-in from the jail medical staff. That was really important. And we needed to understand their requirements, and we really needed to implement the program and the flow around their, you know, operations in the jail, and really a lot of attention to security requirements. And the one thing that we really did, really I think helped a lot, was we reached out to Lorain County Jail and Lorain County Sheriff's Office, because they had a very similar program in their own jail. And jail administrator was, I believe, lieutenant, was over the program, and they had an in-house program. And so we were able to set up a webinar, like a Zoom session between our jail staff and our sheriff and their team. And so, because they're used to hearing from me, but I wanted to make sure that they really heard from their own peers and another jail. And so there's nursing staff, their jail administrators, you know, participated, and they provided us with a lot of good tips, information. They shared about their learned experiences. And I felt that was a really great partnership there, and support we got from them. And our jail staff then was able to really learn from them directly. So that was really great. And if you can do that, I mean, that really kind of gets you halfway there. So of course, being, you know, flexible, open to learning, really changing things as needed was really important. I want to say one of the things we did, of course, that really that helped us get buy-in from the jail and the county commissioners, is that part of the grant we really dedicated to supporting, expanding jail staff, providing additional funding to, you know, increase nursing staff in the jail to support the program. And so money speaks, money talks. So that really helped a lot to having the financial support and incentives through the grant. Jail was, of course, I mean, they were willing, but I think that gave them extra push there. So the last thing I want to mention is, you know, it's important that, you know, really understand and have some good experience with MOUD. Whether it's an outpatient setting or some other way. Our organization had an MAT program through our community hospital. We had a physician, Data 2000 waiver, and an OBGYN specialist that, you know, started this program a couple of years ago because she wanted to do it. And we were just kind of giving her space and support, but it was under the hospital. And so, but we learned a lot the last 3 years working with her and the hospital, and developed the expertise. And then gradually we transitioned to kind of transitioning this program in-house and making it our own. And we were able to get a SOAR grant from the OMAS to be able to actually do that. So we have now our own MAT program, it's community-based, and we learned a lot through that. We got the TDD license. We were able to get a, you know, pharmacy refrigerator. We were able to implement all these protocols about, you know, receiving and storing, and, you know, and being able to do all that in vitro sublocate. So we had a lot of experience in the last couple of years, you know, how to really do the MAT programming. And that really helped us be able to implement this in the jail, because the jail we couldn't really store medications there. We had to transport, and we had to follow certain guidelines to be able to do that. So that expertise and experience is important. Clearly, you can't really just start an MOUD program in the jail from nothing. You've got to have the experience and be ready for it. So next. I just wanted to share a little bit about our next steps. In the process, the last couple of months that we've been doing the Vivitrol program in the jail, we have run into clients. These are very persistent clients that really want the sublocate. because they are allergic or sensitive to vitriol. They tried it, it didn't work for them. They're good candidates for Sublocade. But we don't have that program, and that's going to be another, it's going to require some new learning, new processes for us to be able to implement that. But we are looking at adding Sublocade as an alternative option in the jail, and the goal is to really provide the maximum choice. And we know that some clients benefit from withdrawal, others benefit from other options. So the goal is to provide as many different MOUDs as possible, with the blessing and the approval of the jail, our partner, making sure that they're comfortable with this. So I have already gotten the green light from the jail administration. I have also talked to our grant officer at PERSA, and they gave me the green light to transfer funds to purchase Sublocade from Vivitrol, or use some other funding under the grant to be able to do this. And we're talking to a jail and a prison in actually Kentucky that's doing the Sublocade program. So I'm trying to learn how they're doing this in the jail. There's some challenges, including how we put someone on Suboxone for a week before we start them, give them Sublocade. So that would be difficult because our jail will not administer or disseminate any medication in the jail. So it's something that we will have to handle through the Freedom Center. And that was the other thing. We had to make this extremely easy on the jail. We couldn't really be like demanding their resources or manpower or staff time. We had to take all the liability pretty much too, that we were gonna do all the entire program and we were gonna be responsible for it. So we are trying to do the same with the Sublocade, really make it easy on them, and but again, do it well so that we have a good outcome, and we don't have something that could really shut down the program. Another thing that we figured out is we have a lot of interested clients in the jail. I call this the jail psychology. So their main motivation is to get out of jail. And they're just willing to commit to anything if it's gonna help them get out of the jail. And I see this with residential or other types of treatment placements. They often commit to plans that really don't work well for some of our clients because they're so anxious to leave the jail. And so a lot of them were under the impression, if they got on Vivitrol and their probation officers hear about it, the judge hears about it, somehow that was going to help them get out of the jail a lot faster, quicker. And so when that didn't happen, some of them just stopped. They declined. They even refused to meet with us. They really that was their main motivation. So, and we understand that now. We didn't, we kind of knew about it, but it was very clear. It's very clear now. So the goal is to explore maybe some incentives, working with the prosecutor's office and the courts to see if we can increase motivation and participation in the program. And if they participate in this, maybe, there's some, they can get some special arrangement. So I'm hoping to explore that with our law enforcement partners. And the last piece is the sustainability of what will happen 2 years from now when the grant goes away. I am pretty confident that our board and the community, this is a priority. So, and I have received commitments that there will be funding through our, local funders to keep this going. And so, but it's something that we really need to look at because that is the main goal here, to really keep it going and make sure that it doesn't just discontinue and at the end of the grant period. So we're working on that, and we're feeling pretty confident that we will have the program as long as there's demand and we can successfully implement it. Next. So I think the last one is the questions. Now you have me and our team. So if any questions, please go ahead.
All right. All right. Thank you so much. What questions, comments, reactions do y'all have?
Okay.
Oh, hey, Carl. Yeah.
Okay. I can't tell if I'm on because we're not in gallery view. So, all right.
You're on.
Okay. Well, the first is it's hats off to all three of you. It was very clear that you have not only a dedication but a passion for this, and that makes an awful lot because the core. We're learning more and more. Science is catching up, which what we kind of know intuitively is that therapeutic relationship it determines as much as any, especially with trauma patients. And so, but I had a question about and your success, okay, and the tightness of how you ran this with the Vivitrol, I think is what is opening up the community, especially law enforcement, then to using other medications, because it'll help with that. Let's say, oh look, they're in capable hands, they've had some success, and just easing into the that recovery is not all cut and dried, like, well, either you're not using anything at all, or if you are using anything, no matter what the reason, then you're not really sober. So especially up here, like in the Akron area, whatever, that's a very strong a bias that you have to deal with. That they look at things cut and dried, and this is not an exception. So my question was, what were some of the financial incentives that you were able to, if you were following, I think Lorraine, you had mentioned Lorraine, community jail. So what were some,
so we don't really have any financial incentives, for certainly for participants. There are no financial incentives, but other than they have access to free services, free medication. Okay. But I think the biggest financial incentive was to probably our law enforcement partner, the jail, and the county commissioners who kind of oversee the sheriff and the jail, and for them to see that this grant brought money into the jail to help with their medical staffing and nursing staffing was I think a financial motivator too, because okay. Once they got the grant, that was that really kind of increased their commitment. Okay. Now they're committed because this is why you're getting the money, is because you're going to support the program now. So that was how we kind of used that to really incentivize them financially, but also in return we got commitment that they were going to support the program and let us implement it and work with us on it.
Okay, different application of when you had written on your slide the incentives. I thought you were incorporating it as part of their treatment, and they're not always financial, but money does talk the loudest for them, whether it's bus pass or helping to pay their rent or whatever.
Yes, that's certainly that's an excellent point. Yes, we do that, and I should say we didn't use the grant funds. We were going to actually do that under the stimulant. We proposed to use stimulant grants to do some incentives, contingency management, but we didn't get that grant. We're hopeful maybe we will get it next time around. Yes, that is going to be, I think, important, because I know that we do SOAR GPRES surveys with them, and some of them are in the jail right now. They did their GPRES surveys, and they're still wanting to hear about their $10 gift card. So we know that works as well. And so, and that's something that I think that we need to explore further. That's a great point.
All right, y'all, we got about 3 minutes. Who was jumping in there? Sorry.
Oh, I was just saying, I think it's great work you guys are doing. I think one thing, and we never really did it here, is really trying to get like law enforcement to be the cheerleader into trying to convince other law enforcement that this is the way to go. And I don't think I've ever seen a talk like that, but I don't know if your group would be willing to see what they think is the positive of the engagement.
Yes, I think that's a good one. In fact, our first project officer asked us to help our another grantee in Butler County to they are desperate to implement MAT in their jail, and they're having a very hard time. So they tried to enlist our help and work with them and get our sheriff and our jail staff to work with their sheriff to be able to really, help them out and get them going. So that's part of, I think we understand being in this field, we understand that importance of that. And so we were like, wow, we're happy to do that for someone else, because we looked to Lorain County and they were very helpful and supportive of us. So I see that having a really good, potential, spreading the word and maybe having more MAT in the jail, if you can get it at that level.
Yeah, I thought that was brilliant. You taught a masterclass on system change, overt collaboration, affirming people, recognizing partners, trying to find shared understanding, and getting role models to come in and teach folks who are similar how to do things. That was brilliant. Nice job. And if I had my psychologist hat on, I would say that I was avoiding closure and saying goodbye. So I wanted to see, does anybody, we only got a minute or so, anybody want to have any parting shots kind of on terms of what kind of where they're going from here, or what it's been like to be a part of this learning community?
Well, I made a point. I cleared my schedule today. I'm Dave Brager. I'm a nurse practitioner at Center for Families and Children. Who I do an MAT program, but blah, blah, with all that crap. I just want to thank you all, and I hope to God this continues at some other point. I hope that there's some other funding source, because it's vastly needed. I have a new, she's not a new NP, but an NP that's been in primary care practice for a long time that I've been getting to come on board, and here you're ending. And I'm like, oh crap, now where am I going to send her? So I do want to thank our speaker today. I'm not going to try to slaughter your name, but I appreciate so much what you're doing in the jail, because Lord knows, I think especially in Lorain County, we know that people are dying all over the place, whether it's Lorain County, but if we could have more jail programs that really support MAT services, I think we'd be, really helping a lot of people. But I just want to sing your praises. This has been an awesome, awesome experience. In case it does end, my God, I'm going to miss all of you, every one of you. So just needed to say that.
Thank you, Dave. I always love when I see you on, because I know I'm going to get wisdom and heart, both. And love you. Thank you. Love all y'all, really. We're all in this. I see you, Chris. Did you want to say something, or did you just say something?
Oh, I was just saying thanks to Dave for what he said. And, what I said this morning is what a great run this has been. And I'm determined to try to find money to keep it going. We all are, in the background. So we do have a couple meetings set up over the next, 2 to 3 weeks, and we'll see what we can get done. So.
Well, you got the right inspiration behind you there, Chris. Anyway.
Anything I can do to help, Chris, please let me know.
Well, I think the quality of our presentation today just shows how MOUD has been expanding and into so many places where we never thought it could reach, and getting the people that need it. So I do hope that we'll continue to do this kind of mutual support and idea sharing. It really has come such a long way.
Thank you, Dr. Marsh. I was saying this morning, Dr. Marsh is a great combination of being incredibly smart and incredibly creative and open-minded. It's a really nice combination. What other
and technical skills?
Yeah, well, yeah, there is that. There is a growth edge. Any other last comments or thoughts or reactions? All right, y'all. Thank you so much. One last time, our CME CE is 33 Merle, 33, M like money, E like everyone, R like Russell, L like love. All right, y'all, take care. Till the next time.